So good afternoon. See, because we are running short of time, we'll straight away go to the speaker.
Sir, already we are short of time and lagging behind the. So please maintain the time, and if possible, please be brief also.
Thank you, sir. At the outset, I thank API Mandya branch for this, giving this opportunity to talk on this quite an interesting topic. Respected chairpersons, Chairman API, and all the dignitaries. So today my talk is on pain management in renal patients. So, pain insists that it has to be attended to. That's what it's always said. So whatever the type, whichever the condition, finally, unless we address to the pain, it's very difficult to convince the patient that we are going to do good for him. Greetings from API Karnataka chapter and my college, Ramaya Medical College. Pain is one of the most common and distressing symptoms among patients with CKD and related to the quality of life with greater psychosocial distress, insomnia and depressive symptoms. Associated with shortening or missed hemodialysis treatment, probably because of the pain, because just now we had a talk on hemobiopsy, probably again a painful procedure. Increased health service utilization such as emergency departments and hospitalization. So many analgesics are typically used in non-CKD patients, but the same when we are trying to apply it for CKD patients, it's not going to be easy. As we know, more than half of hemodialysis patients experience severe pain or moderate pain at least, and a single small study of 130 non-dialysis CKD patients suggested that prevalence of pain was almost 64 to 75%. So it's quite a significant distressing fact that happens. So whenever a patient with CKD or renal disease complains of pain, probably we have this pain assessment strategies, and since it's associated with diminished quality of life, it is often poorly recognized. So the reason for screening pain may be treated successfully if it is identified. There are at least 8 validated symptom assessment tools designed to identify CKD patients with chronic pain. 2 clinically relevant ones are the important symptom assessment system and the palliative care outcome scale. Yes, for probably documentation purpose or our certain regulatory members, we do this assessment, but more or less it is the complaint of the patient and how he is responding what dictates our treatment finally at the end of the day. So these are the 2 different scales on which we assess the pain of CKD patients. Now, why do we get pain in these CKD patients or renal patients? One is comorbid conditions, probably like diabetic neuropathy or peripheral vascular disease. Second, it is related to the primary kidney disease alone. For example is polycystic kidney disease. Third, painful conditions related to dialysis access. Fourth is the neuropathic pain arising from abnormal neural activity secondary to the disease itself, not apart from diabetes. And sequel of CKD, probably the bone pain, which is most distressing in all the patients of CKD. And of course, the renal stones and UTI. I'm not going to touch more into this because it is an entire spectrum of discussion. Now, what are the challenges in pain management? Is it as simple as that? Probably, we always compare this to solving a Rubik's Cube. When you think it's all red, suddenly a blue and a yellow crop up. Here, probably CKD management is the same. So limited drug options, coexistent conditions, and altered drug metabolism. So we have a certain set of drugs which I can use. Now suddenly the challenge is he's not only having CKD, he's having an hepatic dysfunction. And okay, I have some particular drug, now hepatic dysfunction plus he's an elderly. So these are the different challenges which we encounter in a patient of CKD. So easier to talk, but definitely when a patient comes, probably we'll have to look into all these aspects before deciding on treatment. So these are the things: limited drug options, coexisting conditions, and of course altered drug metabolism with coexistent conditions. So I'd like to start with non-pharmacological approach, probably because safer, probably we can really stress upon this to get rid of the pain. Cognitive behavioral therapy, so identify the distressing negative conditions and beliefs, probably psychological flexibility, so we can definitely base stress reduction, relaxation, biofeedback, all these things we can try. Physical activity, graded exercises, depending upon the type of comorbidity he has, coexisting lesion, definitely we can be done. Spiritual acupuncture, yes, one of the methods tried. And finally, education, most important. So probably purposefully I started with non-pharmacological because here this is where we can really step up without any worry for coexistent conditions or comorbidities. Then of course, most important, where we discuss about the pharmacological approaches. So mild to moderate CKD, that is GFR more than 30, treatment of chronic pain is almost similar, but probably I had a discussion with the pain clinic. They say more than 60 is safer to follow the regular protocol. 30 to 60, be a little more cautious. Less than 30, again follow the protocol. So NSH should be typically avoided. So that is something we have to always look upon. As this NSH, not only reduces eGFR, but sodium and water retention do happen and may aggravate hypertension. Already a hypertension treatment in CKD patient is such a challenge. With NSAIDs, with sodium retention and aggravating of hypertension, it's all the more becomes difficult with hyperkalemia. Many clinicians do use low dose of NSAIDs after careful discussion because sometimes the pain is intolerable. Probably this is between 30 to 60, but definitely not less than 30. But again, comes with a lot of caveat and we should be careful. So when we have a patient probably with less than 30, that is what we most of the time see, especially in elderly. So we have the pain different ladder that goes up, from a non-opioid to a weak opioid to a stronger opioid. So when we talk of different drugs, so I'll just put it in a summarize in this table. Probably the first step, acid paracetamol, probably the most recommended, safe, unless patient is having severe hepatic dysfunction, may not be always there. Paracetamol is the safest one. Do not use NSAIDs, codeine, and one drug, tramadol. Probably I'll come back to it because when I discussed with slide with one of my resident, he gave a look because we keep using this drug so often. Then it's of course hydroxymorphone, fentanyl, methadone. That is the second. Probably adjuvants like gabapentin and pregabalin. Sometimes post dialysis we give a certain dose. May not be a very powerful pain alleviant, but definitely yes, being used. Now, what are the principles and dosing for administration? So generally, yes, you can give an IV access, but as far as possible, oral drugs are still preferred or transdermal. But there are certain things like fentanyl, probably where IV is more preferred because we really don't know the pharmacokinetics, how it behaves in a CKD patient. And some patients with mild pain may achieve adequate pain relief with analgesic dosing post hemodialysis, so depending upon the type of pain and what complaints do they get. By the ladder, that is careful selection of analgesics for each step of the ladder. That's what we discussed. So probably we can all start with paracetamol, non-opioid, then opioid. So that sort of a thing we can assess based on the response of the patient. So we have different drugs. So that's what I told you. Tramadol, I'll come back. It's little controversial. First is paracetamol. We do use no dosage requirement necessary and dialysable. But again, the only thing probably is if you have a severe hepatic dysfunction, we should be a little more careful. Tramadol, very difficult because some of the studies do tell immediate and sustained release. Some say do not give sustained release because of the altered metabolism. So yes, less than 30, better avoid it, especially if elderly and patient with seizures. I think we can avoid tramadol as such. May not be the good choice. Morphine again is a good drug. And then, of course, buprenorphine patches are available. I did have pregabalin and gabapentin. These are the adjuvant treatment. So these are the different approaches when we have pain, probably a nociceptive pain or a neuropathic pain, or a mixed nociceptive and a neuropathic pain. We have these different ladders explained by WHO. Depending upon how patient responds, we should be, probably escalate the treatment. So drugs that should be avoided, NSAIDs, morphine, again a question mark, sometimes it is being used. Codeine, anyway not available now. Tramadol, as I told you, certain conditions, yes, but majority of the patients avoid it, especially when it's less than 30 and patient elderly with seizures. Dextromethorphan, profoxifene, yes, again respiratory distress. Oxycodone, again not available here. So holistic care is what finally we'll have to think. Integrated care approach, collaborative team efforts, and individual case plan. So these are the different things we will have to look into while treating these patients. Probably because of the nature of the topic, slightly different. So I did discuss with our pain clinic, it's run beautifully, where how are they practically managing these patients? So first thing is, as I already told you, it is paracetamol, which they do try with varying doses and increasing doses, but not responding. All these hydroxymorphone or oxygen is not available in India. So they said after paracetamol, probably the next drug would be acute severe pain. It is fentanyl. Again, fentanyl, intranasal or patch, no, but IV fentanyl. So that the first stat dose is given 50 micrograms. So that alleviates the pain, brings down the pain. Later on, to continue it, probably 1 to 2 microgram per kg can be given and continue. So that is the first, paracetamol. Then probably severe pain, you can bring in fentanyl itself, because otherwise gabapentin or pre-GABA may not be effective in reducing the pain. And of course tramadol can be used, but tramadol has to be avoided when it is less than 30 and elderly with seizures. Okay. Then probably the third one would be this pregabalin or gabapentin, which I did discuss. And if for a sustained pain, probably the buprenorphine patches. So that is what is followed there. So we can start with a 5 microgram per hour releasing patch, keep it for about 5 to 7 days, watch how the patient improves, and then again subsequently change it. So probably the dose might increase. Only problem with the patch is, as I told you, with renal conditions, with altered metabolism, how do they react is something we don't know. So these are the practical things which are there. With lack of time, I am not going to the renal stones and calculate. I thank again for this opportunity. A slightly different topic, but I just wanted to, few things, how we approach. And something, tramadol, we so often use in a patient of CKD because it is hepatic metabolism. But we should be careful, because the guidelines also suggest, and when we read about it, they say it's avoided when it was less than 30 or patient with seizures, it has to be avoided. But we do use it more. So that's where we have to be careful. Paracetamol, probably first, avoid NSAIDs, tramadol in certain condition, buprenorphine patch, fentanyl. I think that's what we did. Thank you. Thank you.
Thank you, Vishwanath, for completing within the time period. And it's very difficult topic and at a very difficult time also. Thank you very much. Now I call upon all the three speakers for the felicitation.
I cordially invite the chairpersons to hand over a memento as a token of our appreciation to our speakers.